So treatment of ovarian cancer continues to be conceptualized as a combination of two major kinds of interventions. One is surgery and the other is chemotherapy. And over the years, there have been different opinions. Many years ago, the philosophy was that you needed to operate on any and every patient who had ovarian cancer to maximally resect the disease before you initiated chemotherapy. And people underwent, at times, long, difficult surgeries that involved resection of multiple aspects of the intestinal tract because the disease tends to spread to the surface of bowel, spread to peritoneal surfaces, spread to the diaphragm, surface of the liver. And so the distribution of disease made it very challenging to surgically resect the disease to an extent that was considered appropriate. The goalposts have moved significantly in that regard. Years and years ago, we classified people who underwent an initial surgery, they were called debulking surgeries for ovarian cancer, as being successful if you reduce the disease to 2 centimeters or less of residual cancer at any given implant. Well, today, by today's standards, that would not be considered an appropriate debulking or resection of disease. So over the years, it's transitioned to the concept that if you're going to operate, you should try to operate on people where you believe you can resect all visible disease. The problem, however, is that imaging studies are limited in terms of telling us what the extent is of disease, especially when people present with diffuse disease throughout the abdomen and pelvis and ascites, lots of fluid in their abdomen. It's difficult to really understand what you will find surgically. But we've tried to find criteria for saying, well, these patients probably are not going to be optimally surgically resected as the next step in management. And so the disposition of those patients is to start chemotherapy, and we call it neoadjuvant chemotherapy, and to try to treat the disease, reduce the disease volume, cause their ascites to disappear, and then at the appropriate interval, then intervene with surgery to try to resect what's left of the disease, and then give them additional chemotherapy after the surgery in a setting where you're treating what would hopefully be minimal or more microscopic disease. The combination of those two, chemotherapy and surgery, is still considered the standard of achieving the greatest disease control, potential curability. But we also realize that since most people who are being treated in this fashion present with advanced stage disease, most is either stage 3 or stage 4 disease, that you're going to be dealing with relapse in the vast majority of patients. So if 75% or 80% of the patients who present in advanced stage disease, that's virtually the number that you expect who will relapse. And unfortunately, in many instances, the relapse can be as early as 1 year to 2 years after initial diagnosis and after you invoke management. So the trend has been to try to find appropriate drugs that can be used, other agents that can be used after the active phase with chemotherapy ends, and we call that maintenance therapy. And even the concept of that has changed, migrated over the years. A quarter century ago, people thought that if you finished the principal chemotherapy, you should take one of the drugs and continue it in a less intensive fashion for another year. Some people tried treating patients for 2 years with chemotherapy after the initial phase of treatment. And what they learned is you could create a lot of toxicity, but you eventually will see the disease relapse. And as a result of that, chemotherapy that is considered cytotoxic treatment was largely abandoned as a tool in maintenance. And maintenance has shifted to more targeted drugs. The first that was approved in that setting was called Avastin or bevacizumab, which is a monoclonal antibody drug that tries to prevent cells from developing new blood supply and prevent cells that are cancer cells from therefore having access to oxygen and nutrients, and to try to render the cancer cells static. And it's with the concept that cancer cells that are rendered static eventually die. Bevacizumab, however, has not been shown to prolong survival. What it was shown to do was to prevent, to some extent, the disease from recurring as early as it might. And so it extends what's called progression-free survival. The time that a person goes with after they've finished chemotherapy without evidence that the disease has relapsed or progressed. So it's still a drug that we actively use in more recent years, and there are oral drugs called PARP inhibitors. And evidence of the efficacy of PARP inhibitors actually occurred principally in ovarian cancers, and now are being looked at in breast and even in prostate cancers. But these are drugs that essentially try to prevent cancer cells from repairing their DNA errors. PARP inhibitors have been shown to be effective across the board in all patients, essentially with ovarian cancers of this type, and most effective in patients who actually have genetic mutations like BRCA mutations that are either in their normal cells or in the mutations sometimes can occur strictly in the cancer cells, even if they're not in the normal cells. And that's a smaller category of patients. But we've also identified that patients whose cancers make a lot of DNA errors, there are ways to measure this, and it's called HRD. This is comprising probably up to 40% of ovarian cancer patients, between having mutations of their normal cells that are BRCA mutations, or mutations of BRCA type in the cancer cells, or this other category called HRD. And those are patients that actually are candidates for what we call dual maintenance, where they receive the drug bevacizumab and they receive a PARP inhibitor, and their outcomes have been extraordinarily extended.